எங்க கிட்ட காசு கேட்காத வரைக்கும் போடுங்க. தமிழக டீம், அதனால எங்களுக்கு வந்து சட்டம் வாங்கி கொடுங்க. டிராவல் ஆர்குமெண்ட்லாம் இந்த தடவை பண்ண முடியாது.
ஓ கொஸ்டின் கா சிங்கம் நாளைக்கு பிராக்டிஸ் போல் இருக்கு சாம்சங்.
அப்படியா?
இல்லையா? நாட் ஒன்லி இல்லையா?
முடிஞ்சாதான்.
தம்பி ஆரம்பிக்கலாங்களா?
இவங்க வரலீங்களா? அதனால தான் ஜஸ்ட் ஹோல்டிங்.
யாரு? டாக்டர் எலிசபெத் மேடமா?
ஆமா, அவங்களும் வரல, டாக்டர் நந்தினி 2 பேருமே வரல. அதுக்காக தான்.
யாரோ ஒரு ஆள் வந்தா ஆரம்பிச்சிடலாம் சார். ஒருத்தர் வந்தா
இல்ல, ஒருத்தவங்க வந்தா ஆரம்பிச்சிடலாம்.
ஒருத்தர் வந்தா ஆரம்பிச்சிடலாம். மேடத்துக்கு வேணா திருப்பி நான் போன் அடிக்கிறேன்.
Dr. Satyapriyan, is it possible to omit your video images on, sorry, your video from on the screen then? Because it's distracting actually. Elizabeth ma'am is joined. Good evening, madam.
Start பண்ணிடலாம்.
Start பண்ணிடலாம்.
Good evening. Good evening.
வணக்கம்.
Oh, sir. After a long time.
எலிசபெத் ராணி அவர்களே வணக்கம்.
வணக்கம், sir.
Good evening, madam. How are you?
I'm good, sir.
Nice to see you again, ma'am. After
Yeah. After a long time, we are meeting again on this platform.
Thank you. Good evening, everyone. We are just a little bit late due to unavoidable reasons. Let's start the program. The 101st edition of Postgraduate Clinics in Pediatrics by IAP Tamil Nadu. Let us start the day's proceedings with the pediatrician's prayer by our treasurer, Dr. Lakshani. Dr. Over to Dr. Lakshani.
குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோம். எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர் தம் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றும், நல்லனவற்றை உள்வாங்கவும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள்.
Thank you very much.
Ma'am, good evening, madam.
I'm very happy to welcome the eminent teachers who are in this panel for the postgraduate clinics in pediatrics. And I'm thankful to our academy coordinator, Dr. Rajendran, to make sure that this program runs without any snag or a fail. So over to Dr. Rajendran for further proceedings.
Thank you very much on behalf of IAP TNSC and welcome one and all. Respected President Dr. Suresh Balan and President-elect Balashankar sir and President 2021 Dr. Ramesh Babu, our dynamic Secretary Dr. Thirumurugan, Treasurer Dr. Dashani, and on behalf of IAP TNSC, welcome one and all. And I welcome all the central as well as state EB members. And I welcome today's program's chairperson, Dr. Elizabeth Madam. She's currently a professor of pediatrics at the department Kanyakumari. And welcome you, madam. And I welcome Dr. Nandini. She's a professor and professor of pediatrics. Currently is Madurai Medical College. I welcome madam. And I welcome Dr. Rajkumar. Is currently is a professor and HOD Sivagangai Medical College. I welcome Dr. Rajkumar. I welcome all the students from the Sivagangai Medical College. I welcome one and all for this program. Thank you. And madam, Elizabeth madam, please carry on, madam, please.
Thank you very much, and I'm very happy to be part of this program. And I understand that this is 101st, so century is over. And Srinivasan sir is here. That is a great blessing. Sir, welcome and please contribute to this case. So I invite all of you to this program, and I wish all the best to the students who are presenting and all the learners.
Thank you, ma'am. Shall we go to the case, ma'am?
Yeah.
Shall we ask the student to present?
Yes.
Okay, students. Mashanti.
Dr. Dakshani also welcome.
Ma'am, actually you told you were very tired after a long journey, but you look so fresh.
No, I okay. Thank you so much for the compliment. Okay, screen is enabled for the student.
PG students are having some technical problem. They'll join in a minute, ma'am.
Yeah.
That's what they called.
Have they sent the PP to anybody else who can share? So when we are asking some questions or something, the students can post in the chat box the answers. Have they sent the PPT to anybody?
Hello, madam.
Hello.
Good evening, madam.
Fine, ma'am. Satya Prakash, you join.
Yes, sir. Yes, sir.
Screen share பண்ணுப்பா. Screen share பண்ணுங்க.
One minute. One minute, sir.
சத்யா என்ன ப்ராப்ளம்பா?
ஷேர் ஆக மாட்டேங்குது சார். அது டாக்குமெண்ட் ஷேர் ஆக மாட்டேங்குது சார்.
இல்லப்பா, டாக்குமெண்ட்லாம் நீ ஷேர் பண்ண வேணாம்பா. நீ ஓபன் பண்ணிருப்பா. உன்னோட கம்ப்யூட்டர்ல வந்து பவர் பாயிண்ட் ஃபைல ஓபன் பண்ணிட்டு ஸ்கிரீன் ஷேர் பண்ணுப்பா. மோர்ல வந்து பிரஸ் பண்ணு. அதுல வந்து பாத்தீங்கன்னா வந்து உனக்கு இது வரும், ஸ்கிரீன் ஷேர் வரும். அந்த ஷேர் ஸ்கிரீன் அதுல இருக்கு, ஒரு கிரீன் கலர்ல பாரு.
ஓகே சார்.
நீ ஷேர்லாம் பண்ணாதப்பா.
ரெண்டு பேரும் சைமன் பக்கத்து பக்கத்துல இருக்கீங்க, அதனாலே உங்களுக்கு எக்கோ வரும்.
இப்போ பண்ணீங்கல்ல, இப்போ கொஞ்ச நேரம் முன்னாடிலாம் ஓபன் பண்ணி வச்சிருந்தீங்கல்ல.
சிஸ்டம் ஆஃப் ஆயிடுச்சு.
ராஜ்குமார் இல்லைன்னா அவங்க ஸ்லைடு உங்களுக்கு அனுப்பி சொல்லுங்க, நீங்க இது பண்ணிடுங்க.
நான் தம்பி எனக்கு வேணா அனுப்பிச்சு விடும்பா. என்ன பண்றாங்க? ஏதோ பண்ணிட்டு இருக்காங்க. சந்தோஷ், சந்தோஷ்
சார் சார்
இப்போ எனக்கு அனுப்பிச்சு விடுங்கப்பா.
சார் சார் அனுப்பிச்சு விடுங்க.
சரி, உங்களுக்கு அனுப்பிச்சாங்களா?
சார் த ஒன்லி
அனுப்பிச்சிருக்கியா தானேப்பா? 31 ஸ்லைடு இருக்கா தானே?
சார் இல்ல சார், இதுல ஷேர் பண்ண முடியும்னு நினைக்கிறேன் சார்.
பண்றீங்க? நீ பண்ணிட்டு இருப்பா, நீ பண்ணிட்டு இரு. நானும் வந்து என்னோட இடத்துல போட்டுட்டு இருக்கேன். சரியா?
ஓகே சார்.
Can you share at all? இல்ல ராஜ், நீங்க பிரசன்ட் நீங்க ஷேர் பண்ணிக்கிறீங்களா? உங்களுக்கு அனுப்பிச்சாங்களா? இல்லைன்னா எனக்கு ஹலோ இல்ல, we are already 20 minutes late. ராஜ், நீங்க மியூட் பண்ணிருக்கீங்க
சார். இந்த நான் பண்ணிட்டேன் அவ்வளவுதான்.
நீங்க பண்ணுங்க. நீங்க
வருதா ஸ்கிரீன்?
உங்களுது வருதுங்க.
ரைட், அவ்வளவுதான். இப்ப தம்பி இப்ப ஆரம்பிப்பா.
Satya, yes, we can see the screen.
Yes.
Sir,
who is present? Dr. Satya, yeah?
Dr. Satya, please.
Dr. Ramashanti is present.
Sir, shall I start with the presentation, sir?
Yeah,
yes, please.
Yes, let's start.
Thank you, sir. Good evening, ma'am. My case is a 2-year-old female child, second born child out of non-consanguineous marriage, brought by his mother, whose reliability is good, was brought with the complaints of fever, cough, and breathlessness, ma'am. Child was apparently normal till 1 week back, after which she had complaints of fever for 1 week, which was acute in onset, intermittent in nature, which was not associated with chills and rigor, not associated with rash, cough for 1 week, so dry cough. There was no postural or diurnal variation, breathlessness for 5 days, which was acute in onset and aggravated during cough.
So it is a 1 week duration. I think
is
you
it
must
high grade, low grade, or something you have to mention about the fever.
You should also have listed the complaints in chronological order, no? So that we get a chronology of what is happening. So can you now tell it like that?
Okay, ma'am.
Complaints of
A little more about the fever.
Yeah, first you list it. Fever 1 week. Fever and
Fever.
cough 1 week.
Yes, ma'am.
And breathlessness 5 days.
Yes, sir. Yes, ma'am.
Apparently healthy child prior to that.
Yes.
Age of the child is 2 years.
2 years.
2 years. So tell us more about the fever.
Fever was acute,
grade?
ma'am. It's a high grade fever, ma'am. Was
High grade
intermittent. High grade fever, intermittent in nature. It was not associated with chills and rigor, ma'am. Was not associated with any rash. And fever subsided on taking medications, ma'am.
Responding to medication.
Yeah.
Fever subsided, sir, according to medication after taking medications, sir.
Responding to medications. And now the breathlessness is there.
Yes, sir.
Is there any vomiting, any other systems involvement that is like dysuria?
Fever,
Yes,
chills, rigor, body ache, all these things, you have to mention.
Chills rigor she mentioned, not associated chills rigor. 2-year-old. Okay, now breathlessness. So is this child a known case of wheeze? Is it an under 5 wheezer?
No, ma'am.
No. Okay. Go to the next slide.
History of vomiting was present, ma'am, for the past 1 week, 2 to 3 episodes per day. It was non-bilious and non-projectile, ma'am. Mostly in favor of post-acid vomiting.
Usually post-acid vomiting will happen when it is a wet cough or a dry cough.
Wet cough.
Why did you mention it is a dry cough initially? Oh, maybe you overlooked that. Okay.
No
So
history of flu.
this is a wet cough actually, no?
Yes, ma'am. No history of loose stools. No history of rashes and joint pain. History of pica was present, ma'am. Child had habits of eating sand. No history of seizures.
Try to explain that. You have put it in bold. So what does that mean? What is the significance? What are the consequences?
Child has a history of non-nutritive food intake, ma'am. Ma'am?
What is the significance, Pa? What does it do?
More fun for infections, sir.
Which infections, Pa? Infection or infestations?
Infestations. Worm infestations.
So it can be due to iron deficiency.
Yes, ma'am.
But it can lead to helminthiasis, lead poisoning. Both can aggravate the iron deficiency, isn't it?
Yes, ma'am. Yes, ma'am.
Both can aggravate the anemia. Lead poisoning also. Microcytic hypochromic anemia. Okay.
No history of seizures, altered sensorium, loss of consciousness or abnormal movements. No history of crying while passing urine, red color urine, frothy urine, patient puffiness and dripping of urine was not noticed in this child. No history of altered frequency or quantity of urinary output. No history of passing worms and stools. No history of ear pain, ear discharge. No history of bleeding gums, easy bruisability of skin. No history of passing dark colored stools. Past history of treatment was taken for the current illness in the private hospital on OPD basis. History of native treatment was given. Neem leaf juice was given, ma'am. History of hospitalization 1 year back for fever and cough in a private hospital, ma'am. No history of recurrent episodes of vomiting or loose stools. Child not on any medications. Child is not a known case of congenital heart disease, seizure disorder, bronchial asthma, any breathing disorders, and congenital anomalies.
That 1 year back, the hospitalization, how many days the child was the child admitted? Did the child receive any IV antibiotics or only oral antibiotics on OPD basis?
On OPD basis, sir. For 2 days.
Hospitalization. You written hospitalization.
Hospitalization, sir. For 2 days hospitalized, sir. There was no history of any IV antibiotics, sir. And past records were also not available.
So before going to the rest of the story, can you tell us what is the government program to prevent anemia in this age group?
Anemia
Not followed. That is why these children are all anemic.
Anemia Bookbar.
Very good. What is that? Who are the beneficiaries?
Beneficiaries from 5 years to 10 years and 10 years to 19 years children, then adolescents, pregnant women and lactating mothers, and all.
It is a life cycle approach, and it starts from
5 years.
That means you have not read the anemia book, Bharat.
0 to 6.
0 to 6 months, mother should be on daily iron. I must have interrogated at least 100 mothers. 5 mothers said they took iron and calcium 180 days after delivery. Everybody said 2 weeks, 6 weeks, 3 months. Nobody is insisting on that. And then the baby should be started on iron when? Have you seen the MCP card?
Yes, ma'am.
Mother Child Protection Card.
Yes, ma'am.
There are columns 6 months to 5 years bi-weekly iron. It is written Wednesdays and Saturdays. The baby has to be on iron, and you are starting only from 5 years. So that is something which I think we are also highly responsible for not implementing it. That there is column in it 6 months to 5 years. Hardly
actually,
2 mothers out of 100 followed that. We're aware of that.
What she told is only the slogan, the Anemia Mukt Bharat. What was the name? What is the name of the program, pa? Poshan Abhiyan, yeah.
Poshan Abhiyan, sir.
Yeah,
what is the expansion of Poshan?
It is part of Poshan Abhiyan 2.
Poshan
Now
Abhiyan.
it is Poshan 2.
Poshan 2.0.
Prime Minister Acharya.
Solpa Satya. Prime Minister
overarching scheme for holistic nutrition.
Okay. So what are the goals? அதில் நிறைய கோல்ஸ்லாம் இருக்குல்ல போஷான் அபியான். What are the goals? What are the targets by 2022? Originally, when it was launched? Any idea? It was launched in 2018. 2018, and actually they wanted to, they initially they made, actually they wanted to do some goals actually what to be achieved by 2022, but unfortunately COVID actually interfered. COVID came and we couldn't achieve those goals, but at least now we have achieved almost 60 to 70% of those goals. What are the things actually they wanted to achieve? Any idea? Poshan Abhiyan.
It is actually a 6x6x6 strategy. Yes, 6 sets of beneficiaries, 6 sets of goals, 6 sets of intervention. So you have to read. That's a beautiful toolkit, and every postgraduate and every practicing pediatrician should be knowing about it.
Yes, ma'am.
And even the MCP card, you must go back to the ward and see the MCP card. The columns are there, but nobody is filling it up, or even the awareness creation is not happening. Okay. Now let us go to the prenatal and all.
A 24-year-old female second gravida mother was unbooked and unimmunized mother. Pregnancy gap between the first and second pregnancy was 11 months. Pregnancy was confirmed by antenatal scan. Only 3 visits, antenatal visits were had.
Here I have a question. So we say no, the gap spacing. Is the spacing between 2 pregnancies or 2 births? What is the definition? Definitions. 3 years, we say no, spacing should be 3 years.
Yes, ma'am.
Between 2 pregnancies or 2 births?
2 pregnancies.
You have read the guideline? No, you have not read the guideline. Read it. It says between 2 live births. Between 2 births. A pregnancy can be an abortion or anything, no? So between 2 births only they say that spacing, not. Okay, here between the 2 births, How many? What was the spacing?
11 months.
Okay. Between the two births. Actually, we usually draw the pedigree in the family history. I think we can start doing it here so that we will understand the pedigree of that.
Pregnancy was confirmed by antenatal scan. 3 antenatal visits the mother had. Mother did not take the IAP drugs regularly. Had no antenatal complications, ma'am. There was no history of bleeding, spotting, PV, fever with rash, arthralgia, and post-auricular lymphadenopathy. No history of any.
I will say that she definitely would have had anemia complicating pregnancy. You are telling no antenatal complications. She didn't take iron, and soon after her, even before, within 11 months, she's having the second. So how can you say that had no antenatal complications? Have you asked her about her anemia?
There was no history of any iron transfusions and blood transfusions in the mother, ma'am.
That will be done only if it is severe anemia or some cardiac compromise is there. Then only they'll give blood transfusion.
Iron transfusions were also not there.
Okay.
Quickening was felt at 5 months of gestation, and mother was able to perceive adequate fetal movements. Antenatal USG was done once, which was uneventful. The lighter was adequate. History of premature rupture of membranes was present. Leaking PV. There was no history of leaking.
What is PROM? What is PROM?
Premature rupture of membrane.
Definition.
What is the definition? What is the definition?
Satya.
Huh?
Before the
onset of labor. Labor. It doesn't mean that it should be a premature delivery, no? It should be reworded. That is what the obstetricians also now feel. Premature rupture means to some it is, PPROM is prolonged premature rupture of membranes. To some it means actually premature birth. So before the onset of rupture of membranes, before the onset of labor. So this happened at term or before that? That is not clear. It was term?
Preterm.
So this premature you meant for earlier onset of earlier rupture or for premature? It is not clear to me. That's why I asked. What was the gestational? At what gestational age this rupture of membranes occurred?
At 35 weeks.
At
35 weeks, ma'am.
35? How
35
do you,
weeks.
35 and some few days are there. How will you put it? 35?
35 weeks plus 2 days roughly, mother.
So that is also, now we put it as 35 2/7.
Okay.
35 2/7. Like that you have to put it. Okay.
The natal history.
What is this leaking PV, burning, maturation?
There was no history of leaking PV, burning, maturation, and lower abdomen.
There is no history of premature rupture is there. Then leaking PV is there. Burning, maturation is there. Lower abdominal pain is there. No,
Yes.
it is not there. This leaking PV prior to this, during prenatal period. Why you are putting it after the premature rupture of membrane? Now she is into labor, no? Whatever you wanted to say, you could have said earlier. Okay, go to next.
Natal history is a normal vaginal delivery, ma'am. So preterm delivery at 35 weeks.
35 2/7. Like that you must put. Okay. Even every day counts.
Okay. Birth weight of 1.7 kg, ma'am. Baby cried immediately after birth. Was admitted in NICU for a preterm care and low birth weight.
So what is the label of this baby?
Is it preterm AGA, preterm SGA, or what?
Early preterm, late preterm. So you have to qualify and tell us what is the label of this baby.
Late preterm, small
preterm.
Small for gestation age.
Yeah. What was the percentile? Did you check in the intrauterine curve? Any Fenton or? Please mute others.
Less than 10 centimeters.
Dr. Nandini's phone.
I'm so sorry, madam. Please.
Okay, continue. So it is a late preterm and
small for gestation.
You say it is SGA. What is the percentile in the intrauterine curve?
Less than 10 centimeters.
Less than 10 centile. Okay. We know that 34 weaker usually will be 1.8 kg. We say no, 34 weaker can be put to breast. They can suck, swallow and coordinate respiration 1.8 kg. And below that, they need an admission. So this baby was admitted to NICU. For how many days the baby was in the nursery?
9 days of admission was there.
9 days. Okay. Continue.
Baby had a express breast milk feeds, ma'am, initiated on day 2 of life. Baby was on direct breastfeeding from day 6 of life.
What was the difficulty in initiating before 2 days of life? Within a day, within 1 hour, these are all very important parameters, no? What was the cause? Any reason?
Low birth weight and respiratory distress.
Respiratory distress requiring invasive ventilation?
No, ma'am.
Then is it a contraindication to minimal enteral feeding or
NG feeds can be?
Yeah, we could have fed the baby, no? And this hospital has a CLMC. This hospital where the delivery happened has a CLMC. What is CLMC? Comprehensive Lactation Management Center. Bank is there, breast milk bank. Now we don't prefer the term breast milk bank because if it is a bank, a lot of rules and regulations will come, and we don't want to call it drug bank, blood bank, or licensing and all those things. So we call it as CLMC. CLMC is Comprehensive Lactation Management Center. So even if the mother did not have much secretion because it was preterm delivery, pain, sometimes lactogenesis 2 may be delayed. You know about lactogenesis 1, 2 and 3, I hope. Okay, baby was given direct breastfeeding from day 6 of life. Good. So every baby should be initiated on direct breastfeeding before discharge. That is our goal. Continue. Please continue.
Postnatal history, ma'am. The child was on breastfeeding from birth till present, ma'am.
Actually, you are telling about the mother or the baby. Postnatal is for the mother, no? Neonatal is. That is a better term. Natal, neonatal. Am I right?
Yes, ma'am.
Okay. And?
Child was on breastfeeding from birth till at present, ma'am. Weaning was started from 6 months of life. No proper weaning practices were followed, ma'am.
What is the right term for weaning? Weaning, the term is not discarded, no?
Complementary feedings.
Yeah, why you are writing weaning? Complementary feeding. Weaning means to some mothers at least you can stop breastfeeding, wean off and then give the rest of it. That is why we say complement the breastfeeding. Complementary feeding. And all together, what is the term? Heard of IYCF practices? What is IYCF? Infant and child feeding. So 0 to, now that also includes MIYCF, maternal. And the birth weight is a surrogate of fetal nutrition. So 0 to What is the window of opportunity? First 1,000 days. When does it start? When does it end?
Starts from the conception to first 2 years of life.
To second birthday. Actually, it is from LMP we calculate, no? We don't know when the conception occurred. Actually, it is a continuum. The pre-conception is also part of it. The ovum, the health of the ovum. And when is the ovum formed? When is the sperm formed?
Intrauterine.
Ovum is formed in the intrauterine life. And sperm is formed after puberty only it will come. No, spermachy. Sperm is every day it is formed. That is why the aging sperm nobody speaks. People speak only about the aging ovum. And now I was listening to a talk which says about the ovum clock. The ovum clock starts very early. In the intrauterine life, the ovum clock is starting. And it can age faster, it can fail faster. All these things are happening. Now people are speaking about this ovum clock starting in utero. Okay. So IYCF practices. And in how many IYCF indicators are there? IYCF, IJPP, the latest edition, I have written an article as per request of Dr. Eknaumari. Please read that. How many indicators are there in IYCF? Read each indicator. We will feel so guilty that we didn't know all these things. There are 17 indicators. So you must say all that.
Initiation of breastfeeding.
No, breastfeeding, complementary feeding, junk food, then animal milk when breastfeeding is not there, fruits, eggs, everything is there. So please read that. This is a sensitization class also. So IYCF, how many indicators were fulfilled? That is what you have to tell. Previously, ragi was given, we were satisfied. Now we have to say about minimum dietary diversity, minimum meal frequency, minimum acceptable diet. I am not going to ask you any of these questions because you are not at Reddit. Please read it. Next time I'll ask you about that. Go to the next. IYCF practices. 17 indicators are there. We are responsible for disseminating the message and also seeing that every baby under our care fulfills that 17 indicators. Okay, next.
Immunization history. The birth dose vaccination was given. BCG scar was present. Last vaccination dose was at 45 days of life. Child was not properly immunized.
This baby has a name, label. What can you tell that label? What is the label of this baby? This is called as
unvaccinated, incomplete vaccine.
Partially. But if the baby had not received 45 days injection, we call them zero dose children. Who is a zero dose child? A child who has not received any vaccine other than the delivery package. The delivery package is given without their motivation, no? The hospital gives it, thrusts it upon them. So zero dose children. Similarly, there is a term zero food children. That is also from one of the IYCF indicators. There is an article in Lancet, May 2023, which speaks about zero food children in India. Okay, please read that. Go to next.
Family history is a second order born female child out of non-consanguine marriage.
Actually, you must put the year of birth of the people so that we know. Don't write 1 year, 2 year, etc. because this record will be carried on, no? Next year, they are not 2 years, no? The child will be 3 years. So it is in Western countries, they put the year of birth. Okay. Or even the father, mother, everybody, the child, year of birth they put. Okay, continue. Continue.
Developmental history, gross motor milestones, neck holding was attained at 6 months, rollover at 6 months, sit with support at 8 months, Sit without support at 11 months. Stand with support at 12 months. Stand without support at 18 months. Walks without support at 2 years. There was a gross motor delay was present. Fine motor. Unidectus gas was at 6 months. Immature gas is 9 months. Mature pinches gas at 1 year. The child scribbles by 2 years. Social milestone, child recognized mother. Social smile at 4 to 5 months. And plays a simple ball game by 1.5 years. Language, monosyllable words at 8 months. Bisyllable words at 10 to 12 months. Jargon speech by 2 years. Inference, the child had a gross motor delay was there.
You have to put the developmental quotient also everywhere, rather than putting it like this. So now your interpretation is that there is a delay in gross motor. What do you attribute that to? That is attributable to what?
Nutritional deficit, nutritionally child.
Yeah, malnutrition causes delay in gross motor milestones. Can you give any reason why malnutrition causes delay in gross motor? Myelination is in the brain and the nerves.
Muscle wasting, ma'am.
Yeah, wasting. The child should have strength to walk and climb and all, no? So muscle wasting is one. Any electrolyte imbalance you can think of? They can have hypotonia.
Hypotonia.
And electrolyte imbalance.
Hypokalemia.
Yes, potassium.
Yeah, hypokalemia. It can cause like flaccid paralysis. The muscle won't be strong. So hypokalemia, hypotonia, muscle wasting, all these are the causes. And maybe the socio-economic, no stimulation, nothing, no support, social support for the child and the mother. Okay, psychological reasons also. Okay, go to next.
Diet history. Diet history, breastfeeding is continued till 2 years. At least 7 to 8 times per day, mother used to feed along with complementary feeds, which was started from 7 months of age. No history of bottle feeding or formula feeds.
Yeah, but we don't know about the dietary diversity, frequency, minimum acceptable diet. These are at least the minimum things you must ask in this period. Okay, now the current diet. Okay, we'll go a little faster because we have lost a lot of time also. So give your comment on this, whatever you have got as the history.
As per the history, the child had a deficit of 650 calories, ma'am.
Go back. So what is your comment on the items that the baby is getting?
Child is not getting proper.
How many food groups are there according to IYCF, and how many should be given daily? How many food groups are there? IYCF. There are below 2 years, up to 2 years, 8 food groups are there. And at least 5 should be given in rotation. So learn all that, 8 food groups. That is all there in the article which I wrote in IJPP. You have IJPP in your college? Oh, get access to that. Huh? Okay. So here, what about tea and biscuit? Biscuit is actually a ultra processed food. It comes under junk only. Huh?
Junk food, sugar.
It comes under junk. Tea is not the beverage for the child should be water only, no? And even the junk guidelines of IAP does not recommend fruit juice below 2 years. So read the junk's guideline also. Huh? Idli sambar okay, rice curd okay. The rest of the food is not suitable for the baby. Nutritionally inappropriate for the baby. So it is one among the junks. Huh? And so now go to the next. So your interpretation is that it is deficient in energy, protein,
Yes, ma'am.
And is it a complete protein or an incomplete protein with rate limiting amino acids?
Ma'am, incomplete proteins, ma'am.
That you must highlight. How can the baby make all the protein synthesis when certain essential amino acids are lacking? You know what are type 1 and type 2 nutrients? What are type 1 nutrients? What are type 2 nutrients? No. Read. Huh? One is functional nutrients. And you can run a program and store it up like vitamin A, iron, etc. Type 2 are growth nutrients. Every day it has to be supplied. It cannot be stored. So learn about type 1. It is there in my book also. Type 1, type 2 nutrients. So you are only bothered about energy and protein. And you are not bothered about that it is an incomplete protein. No non-vegetarian source. Now no breast milk also. No other milk is also there. Only the tea. Tea must be black tea. They may be giving. Who knows? So no good protein is there. What about micronutrients? You must tell about that. It is deficient in energy, protein, and micronutrients.
Yes.
And then the next thing is the baby on any supplements? The baby is on biannual vitamin A. Then you score for that. Baby had diarrhea and had zinc recently. Then baby is on iodized salt, we can say. And baby is on biweekly iron. This baby is entitled to be on biweekly iron, no? If there is anemia, the baby should be on daily iron. Otherwise, the baby should be on biweekly iron. Next. So micronutrients, quality of the protein, everything is very important. Learn type 1 and type 2 nutrients. Then you will have more insight in interpreting the diet of the baby. I must say the IYCF, everything collapsed. All the 17 indicators collapsed. Read the 17 indicators. That is value addition to your presentation and your practice. Next.
Socioeconomic status, a 10,000 migratory population, ma'am, open air defecation, uses bore water for drinking and household purposes. Child was not given water without boiling. Father was uneducated and mother was also uneducated. Monthly income was around 5,000. According to modified Kupaswamy scale, the family belongs to a lower class family.
Okay. Kupaswamy scale was revised last when?
2020.
To 2021, 22 or anything else?
21, 22.
23 it has been revised. So every year they revise the income. Even the article has come. 2023, Kupaswamy modified the income. They every year they revise it. Okay. So 2023, you must now learn 2023. Next.
Summary. A 2-year-old female child as a second owner born child out of non-consanguineous marriage, a preterm vaginal delivery, belonging to lower socioeconomic status according to modified Kupaswamy scale. The mother unbooked unimmunized pregnancy, child with incomplete vaccination with a delay in gross motor milestones, was brought with an history of breathlessness, fever and cough, with a dietary deficit of 650 kilocalories and 3 grams protein. Probable diagnosis, bronchopneumonia with undernutrition.
Okay, we will discuss this later. Okay, now I have one more question for you. How do you rate pregnancy weight gain?
Pregnancy weight gain for BMI of mother less than 18.
It should be according to the pre-pregnancy BMI. So do you know? So whenever you are presenting such cases, we must know whether the mother has anemia, what is her BMI like? That information is also good. Okay, go to next.
General physical examination. Child was conscious, recognizing mother, not interested in surroundings, and baby was irritable.
What is that? Can you put a label for that baby? I'm asking for labels. This baby, not interested in the surrounding, irritable. Usually a 2-year-old will be bubbling with happiness and will be exploring the here and there, no? will be interested in everything around them, no?
Definitely. Going and pulling everything, pulling and pushing.
Yeah. Or everything they will be attracted to. Anything and everything they will be attracted to 2-year-old child. Huh? And this child is not interested in surround, apathetic. Huh? That term. Huh? Because you are presenting a malnutrition case, no? So such terms should come. And the baby was tachypneic, you have written. What is the respiratory rate?
44.
Yeah, you have to write that. Huh?
Written, ma'am. Excellent.
44. Okay, next.
Pedal was noticed, ma'am. No in palms and soles. There was no pedal edema.
Was the mother pale? You said mother had no antenatal complications. I am sure she must be anemic. Okay, next. So how many vitals are there? You have to say. How many you have written? 1, 2, 3, 4, 5. You have written 5. I want 7. How many vitals are there? Temperature, the baby was febrile. Good. And pulse rate, you have written. Respiratory.
BP was 90-60, ma'am, in the right upper limb supplementation. SpO2 was 98% in.
Suppose I say this baby is in impending shock. What else you could have checked?
Capillary.
Yeah. CRT is very important here. You must write. 7 vitals. And what is the 7th vital sign? So the 6th is CRT. And 7th is blood glucose. Blood glucose. GRBS. So 7 vital signs should be there. Where will you triage this baby? This baby, you know, is malnourished and is having dyspnea, tachypnea. Where will you triage this baby?
In pink.
Pink. IMCI, pink. Pink is going to get critical care sometimes, no?
Yes,
yeah, fast breathing, if not feeding well, malnutrition, maybe SAM. So GRBS is very important. Anybody whom you triage into pink should have the 7 vital signs. CRT. BP may be maintained. Postural hypotension only they will have, but CRT may be prolonged. Okay. Hydration is adequate. Why do you say? I say it is not there because the child is irritable. Sensorium is altered. There is tachycardia.
Febrile.
Yeah.
Mild dehydration might be there.
And hydration is adequate. Why do you say? Why did you put it hydration there? And why do you say it is? You check the
skin moved so quickly.
So you was maintained.
The tongue was not so dry, ma'am. Mucosa was not so dry. There was no sunken eyes. Tears, eye film was not. Tear film was.
Okay, each one you can say in the head to foot examination.
Yes.
Okay, next.
Head to toe examination. Head was in normal shape, size, and there was no frontal.
What are you likely to miss if you go by head to toe? What are you likely to miss? Hand to head to foot. We have very good students who have missed the polydactyly and telling it's a heart disease. The next mediocre candidate will come and say it is Altora because they detected the hand anomaly. The other one head to foot. So if you strictly go head to foot, you may miss the hand. Don't forget that. I'm just joking with you. Okay, head is normal in shape.
The size, no frontal gaussing, anterior fontanelle was closed. Hair was lusterless hair, spare hair, thin, easily pluckable, brown in color, no areas of color.
Are you using more than one device? So lot of echo is there. You are using more than one device?
No, ma'am.
Okay, then go.
My face, there was no dysmorphic face. Eyes, pallor was present, no interest. Ears, no low set ears, no discharge. Oral cavity, lips, tongue and was normal, no cheilitis, stomatitis, glossitis, oral ulcers, clump leaf, fresh and no dental caries. neck, there was no lymphadenopathy.
How do you detect pallor in a young child? By into the eye or somewhere else?
And palms and
Palmar pallor. Where is it? That's why I said head to foot. If you go, you will miss all that. Hand to head to foot. It's my picked up. Palmar pallor. The eye, he may cry. He's crying, so I may be congested. And conjunctivitis, anything can happen, no? 2-3 times you do this also, the eye become congested. So pallor may be missed. Better to go for palmar pallor, assuming that you are pink. Are you pink? Huh? I remember Srinivasan sir picking up in one teaching session. He asked the candidate, please check your B12, because her knuckles were pigmented when she came to do the examination. And she said, sir, I am on B12. So Srinivasan sir is there. So are you pink, I am asking. Huh? Assuming that you are pink only, you can assess pallor in a child, no? Okay, go to next.
Chest was normal, no Harrison circles, no racketerosis. Abdomen was normal. Extremities, there was no edema, no hyperpigmentation. Nails were paler, were present. No clubbing deformities, no spooning of nails. Spine was normal. Genitalia was normal, no perianal excoriations. Skin was dry, scaly skin, no dermatosis, no hypo and hyperpigmentation. Skeletal system, no bony deformities.
Okay. Next.
Anthropometry, the weight for age was 7 kg, the length for age was 74, expected to be 12 kg and 89 centimeter. There was the centile would belong to less than third centile. Inference would be the wasting, and the third degree stenting was present.
So except the head circumference, everything was below
third
percentile. So so I am asking, is it below 1 percentile? How do you know? 1 percentile is what I am interested in. So many children are there below third percentile. They are not SAM. So whenever the growth is below third percentile, you have to go for third score. -2 corresponds to third percentile. And -3 corresponds to less than 1 percentile. So this case, when the child is normally growing, it is good to know your child is in the 95th percentile, 50th percentile. When the child is trailing, where is the Z score? WHO Z score you must have.
I have given the image.
It is below, below 1, below -3. Everything is below -3. Do you have the charts?
Yes, ma'am.
And what is the significance of mid upper arm circumference? It is mid upper arm circumference. MAC is gone. Now it is MUAC. Old books speak about MAC. MUAC. MUAC is less than 11.5. Any significance you know? What is the significance of a MUAC less than 11.5?
Severe acute malnutrition.
Severe acute malnutrition and at high risk of dying. So now we know mid upper arm circumference, we have to look at the arm circumference charts, which varies with age. But still WHO is not throwing away this criteria because of 2 reasons. One is less than 11.5 is at high risk of dying. So many, there may be 10 SAM under your care. The one which is having less than 11.5 is at high risk of dying. And second is in resource limited settings, or when after a flood, an earthquake, after a war, all your resources may be destroyed. But still you can find one tape, or I know what is the calibration of my hand and I can say this child is at risk, is SAM. Okay. That is why they are not throwing away. Individual cases, arm circumference charts are better. because it is not a constant from 6 months to 5 years. We know that. But still, WHO is not throwing it away because of these two reasons. So this is a SAM who is at high risk of dying, I'll say. And once he crosses 11.5, I'm happy. Okay. Next.
Then who classification, ma'am? The head circumference.
Good. Next.
Weight for age, ma'am. It comes under the third percentile.
This I am not happy. Where is the centile chart? Without the centile chart, so many children are there below third percentile, no? Below 1 percentile. That is the severe. Huh? Okay, next.
So weight for length.
Again, so many children are there under your care who are below third percentile. Huh? But the one who is below third, -3 Z score, that will be very few children. They are the children below 1 percentile. Because 3 standard deviations will cover 99, more than 99. And then only 1% is left. And that has to be put at the two tail ends, no? So less than 1 percentile. That information should come. So whenever you are presenting a malnutrition case, go for the Z score. Whenever you are presenting a normal case, go for the percentile chart. Huh? Value addition for you. Next. Okay, next. Where is the criteria for SAM is weight for length. Where is your weight for length chart? Weight for length. Okay. The Z score only should come, no?
Yes.
There is the length chart. You showed all that charts. Head, weight for. Where is length?
It's not there.
One is missing. That's why I asked. Okay. All the charts should be there. And who is U6M? U6M. WHO is giving lot of importance to U6M children under 6 months. And now what is new in malnutrition is that they are shifting the focus from weight for length to weight for age. Below 6 months, we need not wait for all the stunting and wasting to happen. We have to pick them at risk stage. So if you read up, we can say U6M, under 6 months of age, everything, every guideline has changed. New guideline has come. Who are SVNs? SVNs, small vulnerable newborns. That is, every hospital, you should have a, like disease specific morbidity, mortality, we calculate, no? Disease specific, like that. How many newborns you had? How many SVN you had? What happened to your SVNs? They are the preterm and the term SCA and even the preterm AGA, preterm SCA, term SCA. What happened to them? That should be have a special care, and that should have a separate morbidity mortality. Even you can give thesis topics, Dr. Rajkumar, SVNs, SVNs in your. So read about SVN. This is all these guidelines which I am telling. All are 2023 WHO guidelines I am telling. Huh? U6M. The focus is shifting from weight for length to weight for age.
Weight for age. 6M and ASV.
Under 6 months. U6M babies. Okay. Next. Go to next.
Respiratory system, bilateral air entry was equal. Bilateral captations were present. Just retractants were present. Intercostal retractants were present. Subcostal retractants were present. And
how many accessory muscles were acting? What was the work of breathing? You said the baby is tachypneic. Once the baby is tachypneic, we have to assess the work of breathing. How many accessory muscles were acting? Did you look for LNAC, strap muscles, anything acting? And your torsional diagnosis was pneumonia. In pneumonia, what retraction do you expect?
Subcostal retraction.
Subcostal?
Intercostal.
No. Lower chest indrawing. Isn't it? Lower chest. Parenchymal disease. That term should come. IMNCI. And when was IMNCI revised last? What is the new IMNCI? Now, it is there only in the latest OP guide. 2023 OP guide, it is all changed. Lot of changes have come in IMNCI. I can share that if into some group if you wanted, or look at the latest 2023 OP guide. The IMNCI has changed. Lot of changes have come. Find out yourself. Even some of what I said as 2023 WHO guideline is already there. Okay, go to next.
On per abdomen, the shape of the abdomen was normal. All quadrants moves equally with respiration. Umbilicus was central and no superficial dilated veins or scars. On palpation, was soft. Liver was palpable 3 cm below the right costal margin. So soft in consistency, sharp borders, smooth surface, and non-tender. Liver span of 7.5 cm. Most phenomenically, bowel sounds were heard.
So what is your impression about the liver span? Is it enlarged or
enlarged?
Enlarged. You must say enlarged. You said that. You must say that liver is. Why the liver is enlarged? Why the liver is enlarged?
Due to malnutrition, anemia.
Why malnutrition? What happens in malnutrition? That term I want.
Lipoprotein deficiency.
Fatty liver.
Fatty liver.
You must say that term. Fatty liver. Okay. Go to next. What up to what time this class is? When to stop?
When you say
9:30, ma'am. 9:30.
9:30. Okay. Okay. We'll start. CNS.
CNS child was conscious, no cranial nerve defects were noted. Motor system bulk was equal in both the sides. Power 5/8 in all 4 limbs. Tone was normal in all the 4 limbs. Reflexes
normal. So within normal limits. Okay. Next. Go to next.
Diagnosis: a case of severe acute malnutrition by WHO classification with severe anemia, with ARTA, IMNCA, severe pneumonia, with the probable etiology being inadequate diet, improper weaning, poverty, illiteracy. Precipitating factor may be repeated ART.
Okay, here you are not highlighting that it was a preterm low birth weight baby, no? Started as a, so you can say that it was this is a preterm baby, low birth weight baby, is prone for becoming malnourished and lot of morbidity, burden of the disease. So you can start from there, and then you can say about that the IYCF practices wrong or suboptimum IYCF practices, then severely underweight, severely stunted, severely wasted, with a mid-upper arm circumference of 11, because that has got this high risk of dying, clinically presenting as a SAM. So I want all that. Where is the stunting? Where is the wasting? Nothing is here. Only SAM you are focusing. And to tell you, the terminology SAM is going to go away. They are going back to stunting and wasting. Again, WHO is, new workshops will now come. Under 6 months, the terminologies are changing, and the terminology SAM is also going to go. SAM and MAM and all. They are going to focus on underweight, stunted, wasted, and mid-upper arm circumference, and with a normal head circumference. Where is the gross motor developmental delay? You have missed that. Huh? And the current diet, the diet which is deficient in, the child is on a diet which is deficient in energy, protein, micronutrients, grossly deficient. And where is the immunization? Partially immunized. A pediatrician should have all these, a comprehensive approach. So all these should be there in your diagnosis. And the examiner will be very happy if you tell all that. Isn't it, Dr. Rajkumar? Huh?
Yes, ma'am.
Where are all these things? Huh? The diet is deficient. You detected so many things, but it is not consolidated into your diagnosis. And severe pneumonia. Okay. So, what may be the organism? How are you going to investigate and manage? We have just 10 minutes. What may be the organism which is causing the pneumonia?
Probably Streptococcus pneumoniae.
Probably?
Streptococcus pneumoniae, most common.
Streptococcus.
Yes.
Or Streptococcus pneumoniae. Pneumococcus. Huh?
Yes.
Which one? Streptococcus is not pneumococcus. Streptococcus pneumoniae or pneumococcus, you must say.
Yes.
Huh? Can it be viral? This is viral season, no? RSVs and all are there, no? Metapneumovirus, RSVs, all. So can it be viral pneumonia? You said bronchopneumonia initially. Virus produces bronchopneumonia because it comes from the upper respiratory tract, not hematogenous spread. Huh? Is the baby having runny nose, cough, coryza, runny nose? Is the baby having upper respiratory tract? I think you straight away went to lower respiratory tract. You didn't tell us anything. Ella naise moving, I asked. Was there any runny nose?
No.
Then probably other family members are also having cold. Upper respiratory tract infection, baby can develop a pneumonia, isn't it? So virus is possible. Then this baby is unimmunized. So anything, no? Even up to Haemophilus influenza. Otherwise, and pneumococci is a high probability. How will you investigate and manage this child?
Complete blood count with all indices to be taken down. Then peripheral smear has to be done.
Now we have to look at the CBC, ABC of CBC. We are having seminars, isn't it? Just from the CBC, you can know everything. Peripheral smear is also not needed. Early iron deficiency, RDW is increased. And microcytic hypochromic anemia. So we can easily detect all that. Anemia. What is severe anemia? You said severe anemia. In the blood investigation, what is severe anemia? What is the cutoff for mild anemia, moderate anemia, severe anemia at this age? 6 months to 5 years. WHO 2017 criteria. No anemia, it will be above
12.
12, 11 or 12? 11. Agree. What is moderate, mild anemia?
9 to 11.
No.
10 to 11 mild anemia.
10 to 11 is mild. He accepts 10. That is putting a signature on the child's brain in the cognition. Even mild anemia can affect all that. And recently, after Sangamam Pedicon, we went to Kanyakumari, that Vivekananda rock, and I got a quotes of Swami Vivekananda, and I was reading that. And it says, we must have iron muscles. In 1892, how did he know that myoglobin is made of iron? Our strength of the muscle is from iron. And then he said, steel nerves. Steel is an alloy of iron, no? Iron is needed for the nerves, plus many other things, LCPs. So we must have iron muscles and steel nerves. I was really so happy to read that. Just his quotes I was reading. Got a small book, 10 rupees it costed me. But the knowledge I got is whenever you go there, you must get that. Huh? So, and what is moderate anemia?
7 to 10.
7 to 10, less than 7 is severe. So to say severe anemia, it should be 7. And when should a packed cell be given?
Less than 4.
Less than 4 minutes.
Without any complication.
Or there is a cardiac compromise, 5 or less than 4 only. And that too within 48 hours of admission. Once the 10 steps of SAM are given, edema fluid will start coming. You are not supposed to give PRBC. If you want to give it at the time of admission. And so now we can take an X-ray chest. We can do the CBC, start learning the CBC. And then hidden infections. You can look for hidden infections like urine. Urinary infection may be hidden. No symptoms may be there. It may be there. So you can do that. Then electrolytes, hypokalemia, very important for this child. Because there is a fatty liver or a big liver, renal function, liver function, you have to do. Steatosis, steatohepatitis, like fatty liver, there may be changes. X-ray chest. Then 10 steps of SAM. We are not going to discuss all the 10 steps of SAM. This baby, how will you start the feeding? Only one question to you. How will you start feeding this baby? Which test will you do prior to that? Yeah. Appetite test. I can see your lips moving, prompting to her. Appetite test. So, did you do the appetite test? Did the baby pass the appetite test or fail the appetite test? If the passed. How do you do the appetite test? How much therapeutic food you must give?
30 grams.
Or any?
30 grams. If the child is less than 4 kg.
Weight into 4 or 5. Some 30 gram or 25 gram you can give. And if baby finishes, how much the baby finishes in
more than
8 hours? So if the baby passes the appetite test, we can straight away go to F100. Otherwise, F70. Will you give milk-based F100 or something else?
Cereal-based.
Yeah, cereal-based will be better. This child is 2 years, no? He would like to eat something rather than drink. And many children don't like milk feed to be given to them, no? But when it is a cereal, it's a semi-solid, they may take. And nobody should take idli sambar in front of the child. Why?
It will, child tends to eat.
Child will ask for it. And what is reductive adaptation? Have you read reductive adaptation?
Yes, ma'am. The child body will respond to the malnutrition. Ma'am. For example, the iron stores will be there. And
one very important word I want, related to the idli and sambar. What is it? Sodium potassium pump will be failing. And they cannot tolerate that sodium. Nobody should take salt containing food in front of that child. Child will definitely ask for it and we will give it. So in the NRCs, there should be separate pantry for the mother to eat. Because sodium, read all that, sodium potassium pump. So, okay, what is the discharge criteria for this baby? When will you say the baby is fit for discharge? When will you say the baby is cured of the malnutrition?
The child should gain weight of more than 10 grams per day for 3 consecutive days. No? The child should have a good appetite.
5 to 10 also is enough.
The midterm circumference should be more than 11.5 centimeter. And there should be no edema.
We need not wait for that. We can say edema clear.
Edema, there should be no edema. And the
weight gain is there. And then
The mother should be confident for preparing you.
Mother should be confident. Good. Very good.
Child should have a good appetite with no infections and underlying diseases should not be there.
Infections are all treated. Then
other complications.
One more thing. Immunization should be completed. Don't discharge them. They will never come back for the immunization. So, what is the program we have now?
Mission
Indradhanush. Catch-up vaccination, which all you will give. We have to decide and give. Okay. And what is the therapeutic food that you are using in your hospital? How much energy and protein is there in an RUTF? 100 gram of RUTF.
30 grams of protein.
How much energy? How much protein?
500 calories, ma'am.
500 calories and
2.9 grams of protein.
2.9 is for the F100. RUTF, I am asking.
20 grams of protein.
15 grams of protein. Learn all that. RUTF. What RUTF you are giving in your hospital?
CPK.
CPK. ICH Chennai is same. We are giving SAT mix, skimmed milk powder, etc. with coconut oil in SAT mix. So every hospital has a program, no? Roughly it should be giving 100 grams should be giving 500 calories and 15 grams of protein. So how much protein we start and how much protein we reach per kg?
0.3 grams per kg, ma'am.
0.3, where is the 0.3? F75 has how much protein?
0.9 grams per 100.
0.9 or at least 1 gram. So we start with 1 gram per kg per day and reach up to
2 to 3 grams.
No. F100 100 ml will give 3 grams of protein, no?
2.9.
You go to 200 ml, no?
6 grams.
So from 1 gram you reach up to 6 grams per kg per day you are going. That information you should have. When will the refeeding syndrome come? It was a question for OSCE station for the DNB, last DNB.
After the catch-up growth and rehabilitation, please, ma'am.
That is nutrition recovery syndrome. I am asking refeeding syndrome. What are the features of refeeding syndrome?
Hypophosphatemia, hypokalemia, hypermagnesemia,
hyperglycemia.
Okay, all that. But which day of treatment it will come?
During the catch-up growth.
No. It usually comes on the 4th day. The question for the DNB was that they resuscitated the baby was put on diet. 4th day, the baby deteriorated. What happens on the 4th day? What happens on the 4th day to get this syndrome?
Child is home.
Energy, but something to do with energy.
Energy, something with energy. They shift from something to something. Okay, read about it. Refeeding syndrome. Read about it. Anyway, very nice case. We must see that the baby recovers. And we must empower the mother. They are migratory population, no? So it's
migratory poor population.
Very difficult. Very difficult. And most of these migratory children have that hair, brown hair, no? So what causes reddening of the hair? Brownish, red hair. Who described kwashiorkor? Who described kwashiorkor? Who described kwashiorkor? Where and when? Heard of Cicely Williams? She called them red boys.
Ghana.
In Ghana. in the Ga language of Ghana. So all the senior teachers know, so younger generation doesn't know. So who is Cicely Williams? You must know. Previously, it was known that if you don't eat, you become wasted. But she is the one who said this edema is because of malnutrition. This straightening of the hair, the skin change, the mooned up face, everything is. And she said it is the disease of the deposed child, of the first child when the second child is born. Here also, when the second child was born, the first child developed the SAM. No? Typical definition. Huh? Dr. Cicely Williams, you must read. Huh? Get the
Cicely
joy
Williams
of reading.
also, fought against Nestle company, murder, milk and murder. So milk and murder, she, boycotted Nestle because in African countries they are giving and they are dying of diarrhea.
Yeah,
dysentery.
read and get the joy of reading.
Yeah, you must read about the history of this lady.
Cicely Williams.
She was imprisoned in this thing, Singapore by Japanese and kept in a cage.
Yeah. So it was a revelation that malnutrition will cause edema, malnutrition will cause mooned up face. Huh? All this was a revelation. And the curly hair of the African children became straight. All this she made. And she said this is the disease of the first child and the second child comes immediately. Huh? So the same thing has happened here also, no? The reddening of the hair may be B12 deficiency. They say manganese, so many deficiencies. That reddening of the hair. Okay, shall we wind up?
Yes, ma'am.
Anyone else? Ma'am, Nandini ma'am? Dakshayani, Dr. Dakshayani, Dr. Vishwanathan.
No, it was very well covered, madam. Very well done. Actually, you are given all sort of the practical things for the exam going students. They have to go and read. You are given all salient.
They have to know in
They have to go and read. But you have covered
detail.
everything. Thank you.
In good detail.
Thank you very much, ma'am. Again, another very nice discussion on malnutrition. And we are really happy to have madam here. Before we close, can we invite some comments from Nandini ma'am?
Good evening, respected persons. I have to thank Professor Rajkumar immensely for bringing me into this Zoom. Maybe this is the first time I've ever entered. So I didn't know how to do a video pausing or an audio pausing. So forgive me for that.
No, ma'am.
Thank you so much. It was a great
It always
pleasure.
happens, ma'am. It always happens.
It was a great pleasure to be with you, ma'am.
Thank
It was
you.
a great pleasure and so much information. And thank you so much. Thank you, madam. I don't have anything to say except to thank you and being a guide for all of us.
Thank you very much, ma'am. Over to Srinivasan sir for his.
So may I say only one word?
இருங்க வரேன் உங்களுக்கு வரேன் நீங்க sir.
Srinivasan sir has no words to say. I am mesmerized by Dr. Elizabeth's knowledge and she has again made me think that I have to again start reading nutrition all over again.
Sir,
sir, you picked up that girl's vitamin B12 deficiency, no?
Yeah,
At
yeah.
Madurai, during
Yeah,
this like this a session only, she
Yeah.
picked it up.
But it's always a pleasure listening to you. There is always something new to learn.
Lot of new things are there. The guidelines are all changing.
Yeah, constantly
Even the
changing.
terminologies are going.
Yeah,
And
constantly
IMNCI,
changing.
please ask everyone to look at the 2023 one, which has come in the OP guide.
Yeah.
Latest OP guide.
Thank you very much, ma'am. Before we conclude, a few comments from Dr. Rajkumar.
Tirumurugan, I am very happy that I passed my exam long back before madam.
Yes, sir.
Okay. So from my side, so first of all, I would like to thank the IAP office bearers and Dr. Rajendran sir, especially. He called me on one day when I was driving and he called me. I was really happy because 101st episode to be hosted by Sivanga Medical College is really a privilege. And that day I called our postgraduate, especially Uma Shanti, because for the last 6 months, he's been after me. Sir, I want to present a case to you. I want to present a case to you. And, now I got transferred to Madurai and my order will come in another maybe within 5 days or within a week. So I told her, you really don't have luck to present a case to me. And 3 days back when Rajendran sir called me, I told Uma Shanti, you wanted to present a case to me, but luck has given you a chance that you are going to present the case to apart from myself, 2 more persons. Dr. Nandini Kupusamy is the current director of ICH Madurai. And God of Nutrition, I told her, God of Nutrition, Elizabeth ma'am, IAP has given you a great chance. So please utilize, read about it and come prepared, come. So I told her. And actually, apart from postgraduates, today I learned a lot from Dr. Elizabeth ma'am. I was relatively stunned. I couldn't speak a word. She was, so that's why I didn't interfere much. So thank you, sir.
Thank you very much, sir. I think all of us had to learn, and I'm very happy. Actually, I've switched over to neonatology and not doing a lot of validation work, but it's still wonderful listening to what Madam's session once again. We thank all the our judges for the day, Dr. Srinivasan sir, and the students who are willing to.
Every 6 months, you invite Dr. Elizabeth for us to get updated in nutrition.
Yes, sir, definitely, sir.
Today she told so many things.
Sir.
And the IJPP article
IJPP article,
yes.
Thank you very much, ma'am, and I definitely hope to see you, all of you again very shortly. And then let's conclude the session. Thank you. Thank you. Good night.
Thank you, sir.
Thank you, sir. Thank you, ma'am.
Good night.